Okay, great. Good morning, everyone, and thank you for organizing such a great session. And I'm really honored to be part of this workshop. And yeah, my name is Zhiyong Lin. I'm currently an assistant professor of sociology and demography at University of Texas in San Antonio. And for this project, I'm happy to have my research assistant, Joseph Jayola, to help me with this project. And today's presentation is titled Household Social Capital and Adult Mortality in India, and with a focus on caste differentials. And I think this study is very closely related to the first one, because first one is about maternal mortality, and my study is talking about adult mortality in general, and results are quite similar. So I think it is a great session to discuss and learn from each other. And yeah, I started this project when I was a graduate student at the University of Maryland. And Maryland is the home to a very great data set on India called India Human Development Survey, IHDS. I will talk more about this data in later slides, but this is a very great data. It is a nationally representative longitudinal study of Indian household. And up to now, they have two longitudinal waves, and they are publicly available in ICPSR. And the third wave is on the field, and it will be available in the uh, next years. And it's I strongly suggest who are interested in the studies to make use of this great data set. So for these projects, I'm interested to look at the association between social capital and adult mortality. And as you know, like social capital is like a very well studied social determinants of health, and tons of studies linking social capital to different health outcomes as well as mortality. And there's in the literature there are different definitions of social capital, but in general, it is defined as the resources to which individuals and groups have access through their social networks. So this project is very early stage, so I really appreciate any feedbacks or comments to further improve this quality of these projects. And as I said, there's tons of studies, but I found that yes, it is strong. Like social capital is in general is beneficial for the health of individuals across different life stages, but I found that literature is quite limited in the heterogeneous heterogeneities among these associations. Are the associations between social capital and health outcomes, is it identical across social capitals, across social groups? I found some studies on gender differences, racial differences, but in some less developed countries, there are very unique stratification system. And in this study, I tried to focus on caste. So, you know, like caste is one of the most important stratification system in Indian society. So my first research question is very straightforward. How is the household social capital distributed across caste groups in Indian household? And one unique contribution of this project is that I tried to measure social capital using three different dimensions. So the first one is the linking social capital. So it is broadly defined as social connections to people of power and authority in society. So literature studies said that it is maybe linking social capital may be especially important in low-income, middle-income, low-income countries because of their limited resources in household. So linking social capital, especially connections to people of power, may be especially important for those from lower-income families. And linking social capital may provide access to information and services from medical providers, schools, and government officials. So in general, literature found that linking social capital is beneficial for the health. So we hypothesized that linking social capital may be associated with reduced mortality rates among the Indian adults. And the second form of social capital we study is we call it bonding social capital. So it measures the trusting and cooperative relations between network members within similar social identities. So it is about social network, social capital within their own communities. So it may provide, but interestingly, like different from linked social capital, linked social capital is like it is always beneficial for health, but for bonding social capital, results are quite mixed. Some found that it provides beneficial effects, such as it provides immediate and necessary support and informational resources for coping with adverse circumstances. So in that sense, it is beneficial. But at the same time, more and more studies found that it sometimes can be come at a price. So it undermines autonomy, and it also lead to mental stress within these communities of the bonding social capital. So the results of bonding social capital is kind of mixed. And lastly, we also look at bridging social capital. It measures connections between heterogeneous individuals groups. So bonding social capital is about connections within homogeneous groups, and bridging social capital is about connections between heterogeneous groups. So it is kind of a very two distinct types of social capitals. And studies found that bridging social capital may facilitate financial and educational opportunities, and it includes a wider variety of resources and information like compared to the bonding social capital, because bonding social capital is more about homogeneous groups. And also it increases access to medical care and other household necessities. So in general, bridging social capital, it is beneficial for the health, and it may reduce the mortality rates of the adults. So our second research question is, do these three forms of social capital have differential effects on the probability of death among Indian adults? And we further look at how it differ by the caste groups, because they may have different distributions of the social capital in these three forms, as well as different returns social capital across caste groups. And I'd like to talk a little bit more about social how we measure social capital, because like different studies using different measures, and in the India Human Development Survey IHDS data used in this study, we measure social capital in these ways. So for linking social capital, we measure it as the among acquaintances and relatives, if there are any like people working in the hospital, clinics, working in schools, and working in government. So yeah, there may be measured in different ways in different surveys, but I'd like to say like in HDS and Indian context, these three may be the most important connections to formal sectors. And for bonding social capital, we measure them as like whether anyone in the household belong to religious or social groups or caste associations. Oh yeah, I'd like to mention that all social capital measures, they are based on the household levels. So that's why we call it household social capital. And in the analysis, we control for the household level variations. And for bridging social capital, we measure anyone in the household belong to these 7 social organizations, like very unique in the Indian context. And all 3 social capital measures are like in the dichotomous way. So it's just about look whether in the household belong to these 3 or any of these 2 or any of these 7. And in general, so we have 2 research questions. First of all, how the social capital are distributed across different caste groups. And second, whether the association between social capital and adult mortality is differed by the caste groups. So it is the broad framework of this project. So let's quickly go through the methods part of this project. So we use 2 different waves of India Human Development Survey. So as I said, the third wave is ongoing. So I really look forward to working to expanding this study using the new data. And it is ongoing longitudinal study. And there are in total of the about 150,000 adults of age 50 and above. And I measure the mortality using the deaths between 2 waves. So there is about more than 8,000 died between waves. Social capital is measured as 3 social capital or dichotomous. And for caste, I focused on the forward caste and other backward caste. These 2 castes are like upper caste, and scheduled caste and scheduled tribes, those like disadvantaged groups. So in this study, I exclude the Muslims and other religious groups to just focus on the caste differences here. So that's one maybe different from the first presentation, which include the other religious groups. And in oral analysis, I control for the age, gender, household, individual SCS, which is the household income and educational attainment. and severity of diseases, and urbanization levels, and really also control for regions. And for the analytical strategy, I used the logistical regression models to explore the link between social capital at wave 1 and probability of death by wave 2, like death between two waves. And let's start from the descriptive statistics. The above figure is about the mortality rates by caste groups. And during the 7-year study interval, we found that disadvantaged caste groups like Dalits and Advasis, they suffer from much higher mortality rates compared to the upper caste groups. And the figure below shows the distribution of sort of capital, the three forms of sort of capital by caste groups. And we found that for linking social capital, upper castes were much more likely to have social links to formal sectors, so linking social capitals compared to the lower caste. But lower caste, especially the Advasis, they have the higher proportions of bonding social capital compared to the upper social caste. And for breeding social caste, it's very similar across caste groups, and there's no significant differences across caste groups. So it is about descriptive statistics. And then we move on to look at how they're associated with the mortality rates. And we found that in model 1, it's about just the caste and controls, and similar to descriptive statistics, there are significant caste disparities. And in model 2, we include 3 different types of capital. And interestingly, we found that linking and sort of breeding social capital, they are both associated with the reduced mortality rates, but bonding social capital is not. To some extent, it is consistent with previous literature, which found mixed evidence on the bonding social capital and health outcomes. And in model 3, we try different interactions like linking social capital and caste, bonding and caste, and bridging and caste, and only the linking social capital and caste, they're significant. And interestingly, we found that the linking social capital is the association between linking social capital and mortality is the strongest among the forward caste, the upper caste, and it's not significant among the lower caste. So to help better understand the interaction effect, I visualized the results, and studies have found that, as you can see here, like linking social capital is associated with reduced mortality only among forward caste and OBC, but it is less associated with Dalits and is not associated with Advasis. And in general, forward caste with linking social capital, they have the lowest adult mortality rates. It's about 4%. And the Advasis, the disadvantaged caste group, they have the highest mortality rates, and it is no difference between with and without linking social capital. So quick summary, household social capital is not equally distributed across caste, and upper social caste, they not only have the largest social links to formal sectors, but also benefit the most from the social capitals. And the lower caste, as you may remember, they have the larger bonding ties, but bonding ties is not associated with mortality. And implications for policy. So considering the unequal distribution and differential utility of social capital, because there is a lot of intervention and policies about improving social capital, but as you can see in this study, there is not equally distributed, and they have differential utility on mortality, at least for mortality. So I think my time is just out, and that's all for my presentation. And I really look forward to your comments and suggestions as well as the discussions.